I've got no disclaimer. So I used the International ERS ATS guidelines for 2014, asthma guidelines. It's important to understand definition before we even talk about severe asthma. So uncontrolled asthma means that there are frequent symptoms. Dr. Deval mentioned that there might be night symptoms, day symptoms, frequent symptoms, and this may even happen in patients that have mild asthma, perhaps due to non-adherence or poor technique or other environmental factors. Difficult to treat asthma means that asthma is uncontrolled regardless of high-dose preventer, and there may be contributing factors such as that the diagnosis is just wrong, there's incorrect inhaler technique, or poor adherence, or other comorbidities such as not treating allergic rhinitis or reflux, and so on. Severe asthma means that the symptoms worsen when a patient is on a high dose of treatment. The symptoms worsen whenever you try and decrease the inhaled corticosteroid. Or the symptoms are uncontrolled despite that you've put them on high dose inhaled corticosteroid and you've actually tried to control or eliminate contributory factors. So this is how we would like to see somebody who's controlled with asthma. We aim that they have no night symptoms. We aim that they have no day symptoms. They don't need rescue medication. They don't need SABAs. They have no limitation to exercise. They're able to play sport. They've got a good quality of life. They've got normal function tests, and they have minimal side effects from medication. The long-term objective in management is really education. We need to educate our patients on the pathophysiology, what actually goes wrong with their immune system, what the role of medication is in managing the disease, skills training, which Prof. Van Zyl will go through later. It's quite important that we educate our patients on how to use their inhalers. Every patient should just have a home care plan. When you have a patient with asthma, it's a must that your patient has a home care plan. And of course, identifying environmental allergens by doing a skin prick test or specific IgE so that you're able to manipulate the environment. How do you assess for control? A well-controlled patient is a patient that has no night symptom. They have less than 2 day symptoms. They use their rescue medication or their SABA less than 2 times a week. They have no or only one exacerbation per year, and their lung function, either as FEV1 or peak expiratory flow rate, is more than 80%. So a patient like that, you would then say well-controlled asthma. However, partially and poor control asthma are those patients that have more than 2 days of day symptoms. They wake up at night, they've got night symptoms, they cannot play sports, they're limited to exercise, they're using their SABA more than twice a week, they've got exacerbations 2 to 3 times a year in partial control, and in poor control more than 3 times per year. And in terms of their lung function, the FEV1 is 60 to 80% in partial control and less than 60% in poor control. And it's quite important that whenever you see your patient in the clinic or in your consulting room, you have to go through the symptoms so that you're able to tell if they're well controlled, if they're partially controlled or poor controlled. But of course, as a clinician, you have to ask yourself, is this really asthma? Should you be thinking about another diagnosis? But once you've established that there is a reversibility and this is asthma, you then have to think about your patient. Is my patient perhaps doing something wrong? Are they really adherent? And to assess adherence, one could ask a question like, so tell me, how often are you forgetting to use your asthma inhaler? And a patient is will be more willing and more honest in their answer versus saying, are you using your asthma inhaler? Where a patient would just say yes or no with closed-ended questions. Of course, you have to use a spacer which Prof. Ansel will go through later on how to use. And you must just make sure that your patient understands the technique. And like Peter said, they have to demonstrate to you as well. So encourage your patients to come to your consulting room with their inhalers and have them demonstrate so that you also know, you can also see that they actually are trained and they're doing the right thing. Expectations, very crucial. The doctor might have certain expectations while the patient has certain expectations. It's just difficult. It's just important to have that open communication with the patient so that you understand what their expectations are. Identifying triggers is quite crucial. There are different triggers. There could be environmental triggers. And for those, one would need to do specific IgE in bloods or skin prick tests. And other triggers are cigarette smoke. Ask them, is there somebody smoking at home or are you smoking? Other triggers are food allergies, strong smells, exercise, and change in weather. And of course, viral infections. The doctor-related factors are, like I said, you've got to ask yourself, is this the right diagnosis? Yeah? And if you're convinced this is the right diagnosis, then you have to ask yourself, am I given the right medication for age? Is this what I should be giving in a 5-year-old, in a 12-year-old? Is this the appropriate dose? Are you under-diagnosing? And it's quite crucial to go back and reflect and ask yourself about your relationship with your patient. Are you educating your patient appropriately? Do they actually understand what asthma is? Do they understand the difference between the medication that they're using, reliever, preventer? Do they know the difference? Do they know what to do? And of course, one has to check for comorbidities and manage comorbidities. We've talked about asthma phenotypes. When asthma is difficult to control and with severe asthma, you have to go back and look for, identify phenotypes. And usually when you get to this phase, it's just advisable to then refer to an expert. My key message is that as a primary care clinician, only 5% of all asthmatics are severe. So a bulk of asthmatics that we see are actually not severe. There are modifiable factors that we need to work on. Patients with severe asthma take up most of the resources in terms of investigation and treatment because you might need to do pheno in these kind of patients and even consider targeted treatment with biologics. The bulk of uncontrolled asthma is usually due to the patient or doctor factors that I've already mentioned, and those have to be addressed in order to achieve good asthma control. I would like to thank Dr. Duval, Dr. Odusute, and Dr. Kiragu for their contributions in my presentation.